Hi, everyone. Welcome to today's webinar, Current and Emerging CMS Payment Models. We're really excited to have Jeremy Powell here from Acclivity Health Solutions. My name is Lori Bishop. I'm the Vice President of Palliative and Advanced Care here at NHPCO, and I'm excited to introduce Jeremy and this topic. Jeremy and Acclivity Health Solutions have become one of our new EDGE partners. And because we have signed a contract with them as an EDGE partner, they are providing discount for their services to NHPCO members. You can find more about that on our EDGE webpage online, and we'll have access to that at the end of the presentation. We wanted to get started just to give a sense of who's on the webinar with us here. So we're going to start with a polling question. So can you all participate in this question? Are you providing community-based palliative care today? And maybe while people are completing the polling, Jeremy, does that matter to today's presentation, whether someone's providing community-based palliative care services today?
So no, actually, part of what the federal government has done in this program is to reduce limitations about how hospice can actually access the potential patients and families with needs. And so no, you don't need to have a community-based palliative program or an advanced illness model or any other pre-hospice services. The expectation from the federal government is that you're going to become a practice anyway, which is so very different than a palliative or an advanced illness model or any other approach you might have taken, that this program will allow you to participate truly as a hospice alone. Those things might be additive, but they're certainly not a requirement.
Great. And you can see our results on the screen. Looks like the majority are saying yes, they have palliative care services today. So thank you for that. We'll have a couple more polling questions throughout the presentation. And I think without any further ado, I'm going to turn it over to you, Jeremy.
Thanks, Lori, and thank you all for giving us the opportunity. I think, if I'm honest with you all about what we're about to face, having had the experience as Acclivity Health Solutions of really providing support in a very similar way, if you unclick edit, you'll be fine, I think. Enable editing at the top. There you go. All right, so one of the things that you would expect us to be able to provide is a sense of accomplishment prior to SIP. So the team at Acclivity Health Solutions has been providing outcomes like this for primary care first, like products. So CPC Plus is the precursor to this. We have experience there. ACOs, the formation of accountable care organization and the management of them, we have capabilities there. We also had bundle experience. We also had chronic care management and complex care management model experience. So part of what I hope you hear today is that you're going to have a trusted partner and advisor. NHPCO certainly sees that as value. What we provide is that experience to help you thrive in all of these changes that are going to take place as we go down this particular road together.
Great. Shall we? Okay.
Perfect.
Thank you.
All right. So hopefully now you guys are seeing the full screen on your side. So I'm going to ask if my voice isn't loud enough, or if it's in any way jumbled from an audio perspective, if you'll just chat to us, that would be great. Also, if you can let us know, please, that you're seeing the full slides and that this is fully rendering on your side, that would be great as well. So like I mentioned, there's a whole host of experience we bring to the table. And what I hope you guys get out of the webinar today is the opportunity to understand a little bit further about why Medicare does what it does, specifically as you see the urgency related to the number of programs CMMI has pushed out. They've pushed out 42 programs since the inception of that particular organization. And if you think about the lion's share of the work that they've done in those programs, it's really been aligned to what they're going to do with the SIP program in primary care first, which is to attempt to diminish the total cost of care, specifically as it's related to the acute journeys that most of our patients go on. So we'll talk about their urgency, the why and the why now, We'll also talk a little bit about how they action their strategy. We'll get into terms they like to use around value, and you'll understand what that means once we get into the political components of this. We'll talk about how a hospice agency itself is going to face new competition. So it doesn't matter whether the MA carve-in or certificate of need or any other change happens, this program is going to create new competition. We'll talk about what that means to you all as an agency, as an organization in hospice facing that part of the health ecosystem. And then lastly, we're going to really focus our attention on ensuring that you can thrive in this new economy. So next slide. The components for us to think about here are, what would you want to leave knowing? And we think you're going to want to know, how will the seriously ill population affect your agency? We think you're going to want to know how today the services that you're rendering and any pre-election service that you provide now get paid for. We think you want to know what a pipeline will look like. Imagine having 12 months worth of pipeline for all of your hospice service. That would be, I think, unnatural for us today to have that experience. You're about to have it in spades, so we'll talk about that. And then obviously, because you're going to be able to control your own destiny in this program, not only can you increase your own referrals through this program, but you're also going to have the opportunity to work with new players and payers in this new paradigm. And then the last thing, no margin, no mission. I know we talk about that often in this part of the world. We believe that you can make 20 to 25% gross margins in this program. So we hope you leave this particular webinar knowing those components. So now I'm going to get into some of the weeds about why Medicare is doing this and why the urgency. So I always like to use something called cognitive empathy. If you think about your role in either the Obama administration or the Trump administration, and your job is to keep Medicare itself solvent, you think about the problem on the screen quite often in that role. Well, I think most of us on the phone think about that about our own agencies. Like, where do we fund the needs for the patient care that we deliver? And if you change out payroll taxes and premiums and general revenue transfers to the foundation, the Medicare payments, and on and on and on, you can put yourself cognitively right in the same shoes that these folks in both administrations have been wrestling with. The reality is that this particular funding mechanism, these funding mechanisms will actually not cover the entire needs of Medicare. And that happens whether you look at a model from the Obama era or from the current Trump administration. That happens in the next few years. So CMS has this urgency to create more and more models only because they don't have a mechanism to fund Medicare proper. And so the things you should know about this from their perspective, so again, putting ourselves in their shoes, is they don't have new levers. Whatever they put forward as a budget, as a set of expectations, those projections are going to have some bias. We think they're optimistic today. We don't think we're going to see the level of GDP growth rates. We don't think we're going to have the same savings rates that are accounted for in those previous models. And the reasons that that's potentially perplexing and compounding the problem is Medicare is growing much faster in this number of beneficiaries than we are in folks that are contributing to the fund itself as taxpayers. As those of us that are earners, we aren't growing the earners as much as we are the folks that are using the service. So the reality is we have this deficit. So whether you sort of believe us or you believe the models, the reality is Part A bankruptcy is in the next 6 years or so. So imagine if we don't create some new paradigms that specifically align to reducing the total cost of care. People who are in positions of power today are going to have on their particular names and in their reputation and as part of their legacy, being part of the team that allowed Part A and Medicare itself to not be well funded and to have issues related to solvency. Here's the big problem. You face it as an agency all the time. If we have a shortage, we either have to cut what we supply or we have to find new funding from the foundation or otherwise. The problem that CMS specifically has is go and Google the last president to attempt to run on a tax increase. I can show you the outcomes of that opportunity. It's not popular. You won't get votes. This is the electoral map from that particular kind of platform. So it's not a mechanism. You can't stand up on any stump anywhere and describe, well, I know how to solve the problem. We're going to raise revenues. So here are the guideposts and the common elements about how CMS specifically thinks about what it is that they're going to do to fix this problem on the right. So you've seen versions of healthcare spending as a percentage of GDP forever. It makes the news all the time. We overspend and we don't have quite the quality of other, other systems. And so there's all this rhetoric around, well, we're different, we're the state, we're privatized. All those things are true. The problem is there's still the politics of how do you fix this problem? We can't consistently run at this rate and expect to have any different outcome relative to the solvency of Medicare itself. So people who try to solve this problem do it from a position of quality as the answer. Quality is the answer. You can stand up anywhere on any stump and say, I'm going to improve the quality of healthcare. You can show infant mortality. You can show length of life. All of those things we follow behind many of the other countries relative to those measures. And you could say, I know how to fix the problem. Let's increase the quality. That will get votes. That will allow you to create new models. That is why these models come out. It also needs to be patient-centered. How many things have you heard from CMMI or CMS that isn't truly around the patient and centered on their specific needs? The other thing it will need to be is not about process. It is about outcome. Anything that's tied to value is tied to the clinical outcome and therefore driving the financial outcome. And oh, by the way, there's no magic numbers or fuzzy math or any other thing you can apply. We're not moving back to 12% ever. We'll be lucky to get back to 15%. And if we do that, it'll largely be because we've created these kinds of programs. So Medicare itself starts, in essence, trying to build high quality programs that address the outcomes of certain kinds of journeys and put those as a premium above the volume of those same kinds of journeys. And so a big example of that are related to the ACOs. So an accountable care organization is part of the Affordable Care Act, which the press calls Obamacare. If you pay attention to when HITECH and the Affordable Care Act came into law, you'll recognize that that was the creation of an accountable care organization. CMS always tweaks and creates new renderings and concepts based upon the original theme. So there are now, I think, 8 different versions of the accountable care organization type. And if you look at what SIP and primary care are tied to, there are also direct contracting capabilities, which really are a form of an accountable care organization. So that would make 9 different types of flavors for the ACO. So be mindful, this is just a lesson on paying attention to the fact that the federal government recognizes that you can create incentives that allow for quality to be the cornerstone of success and still achieve diminished cost in those particular scenarios. So this is an example of one of those first rolled out and really deployed in, say, 2011 or 12. This is the mechanism today of that iteration that's happened since 2012. There are now all of these different flavors, the different concepts that have been rolled out against that original theme. So if you put yourselves back into that cognitive empathy sort of role, the federal government, in an attempt to make sure that it can meet its requirements to have a solvent Medicare fund, has been consistently pushing more and more of the risk down to the providers, and in essence, making them be the bearers of this particular conundrum. The cost that we have is outpacing what we're collecting in revenues or taxes in their instance. So important to know they're doing this because they have to, important to know that they only have so many levers in their hands, important to know that this Primary Care's First program is going to be the first of its kind, but let's be honest, it's the third of its kind because it came from Comprehensive Primary Care, and then the next iteration was Comprehensive Primary Care Plus. You're going to pick up later on why primary care is a misnomer in the SIP part of this, but I want us to pay attention that this program is going to iterate even as SIP comes out. It's going to iterate and find new concepts that allow us to all find higher quality and lower cost as part of the component that make up these individual programs. So let's talk about diagnoses. So it's often been this idea that we should just be able to treat patients as they have needs. And what you find when you look enough under the covers is that there were certain types of patients that in essence were never in any kind of clinical pathway that was repeatable, that there were the same kind of practices being implemented across different parts of the United States, different socioeconomic classes, different patient types. And so the first big studies based upon diagnoses was tied to these two here, end-stage renal disease, and then the oncology, and we're using air quotes ACOs here, because they really were different kinds of models that are going to be rolled into the traditional ACO. The initial results have been incredibly positive. The federal government will release the service year 2018 results. Typically that's done in October. What you're likely to see though is like the serious illness program, those things were CMMI initiatives that are now becoming CMS initiatives and being sort of amalgamated into the traditional ACO. So look for that same kind of playbook to be actioned around SIP and primary care first as well. So I believe here is where we want to ask our next polling question. So if you don't mind, if you would take a chance at, are you considering contracting with primary care first? Sorry, let me read that again. Are you considering contracting with a primary care first participant to help with high-risk populations? And we'll let this run until we get the majority of you guys voting. All right, so it's about 60% of us that are now voted. Is that now being broadcast? Perfect. So if you see here, I think this is pretty typical of what our experience has been within the hospice work that we've done, but don't feel like this isn't representative of all the work we did in the acute space when the reimbursements were being shifted based upon readmissions. Don't feel like this is different from how primary care has adopted CPC Plus or the ACOs. This is very typical. There are complexities that are unfamiliar, and so what I would suggest is we're probably going to do a number of these polls in future webinars. I think I get to lead 2 more if I'm right. So we'll see if these change over time. But part of what I think you should recognize is this is typical. And it's common for us to feel a little bit of discomfort when recognizing that this is the beginning of what will be the first material, and they're going to do it in bites, but the first material change to the hospice reimbursement paradigm since 1985. All right, so let's talk about the topic of the day. So the federal government had been building on a program called Comprehensive Primary Care. It had rolled that program out across a number of markets. It opened that program to primary care as we know it. So I'm going to make sure I use vernacular that's really going to clarify what we mean by primary care in this, because there's sometimes it's a misnomer and there are sometimes that it's accurate. So in the comprehensive primary care models that were first rolled out, there weren't quite as many of these markets that you see being rolled out in January, the map on the right, but they were really focused on trying to build a patient-centered medical home, which is where you could have an opportunity to engage the patients and truly deliver managed care. They were wildly successful in getting persons as practices to come into this primary care model. And they were wildly successful in getting the Medicare Advantage payers to also come in and fund the Med Advantage parts of Medicare under these models. CPC became CPC Plus. It opened itself up to more iterations about that concept. It also opened itself up to more markets. And then this particular instrument from CMMI is the third iteration of comprehensive primary care. So it's now called Primary Care First. The reason they changed the name has to do with the level of complexity that's been diminished. There isn't as many requirements for us to be able to get through the application. There aren't as many quality and reporting components that would be seen as difficult for any agency or practice to perform against. And they're now capitating and paying the payments far earlier. So this is a much more financially attractive and less regulatory or process-driven program than any of the precursors before it. So think about what Primary Care First is at the top. Primary Care First is going to be set up to honor primary care practices who themselves have been able to build case management into their type of care, meaning they coordinate care well, they leverage the cardiologist, the nephrologist, the neurologist, the pulmonologist really well. So think of it as narrowing a network. And those that narrowing ensures that they are still seen through plurality of care as being the quarterback of all care being delivered, because again, they have the total cost of care as part of their charge in this world. So there's going to be a primary care component, and then there's going to be a seriously ill population component. This is a very different approach than, say, taking care choices and retooling it. This is saying, I'm going to take a significant part of the Medicare population. Their estimates are between 4 and 6% of total Medicare and Med Advantage, and they're going to pay for an agency who can provide specific kinds of care to allow them the opportunity to transition to the primary care promptly if that's a need, or pay attention. This is the great part. You can, in this particular program, you can actually refer to yourself as a hospice. So a transition type program like this really allows you to care for the patient for about 12 months, with the output of that care being driving them back after stabilization back to primary care, or if they can't be stabilized and they qualify for the benefit, converting them over into your hospice program. Thank you. Whoops. All right, so think about what this potentially means to us in this particular example. There is a need for us to understand that in all of these states, there are 22 statewide initiatives that roll out for Primary Care First and for the SIP program. Recognize those here, the little beacons that are around the Kansas City market, the Cincinnati market, the Philadelphia market, the Hudson Valley market, and the Buffalo market are all the markets that aren't statewide, but then the rest of them that are in blue are statewide. So the federal government wants you to think about these particular components as if you were going to make a run at converting yourself into a posture that can accept 4 to 6% of the total population. Now, if you're paying attention, that's about the decedent rate for Medicare. So if you think about what hospice typically gets to do for those patients that die in any given year for Medicare, they see anywhere from 20 to 40% depending upon your state, county, or market. So imagine now the federal government is going to give you the opportunity to take charge of those patients and to give you the ability to pick up where they're fragmented in care, where there are issues related to the kinds of transactions that are important. I always use this example. If you are ever in the unfortunate circumstance to be in the path of a hurricane, that's a phenomenal thing if you're a healthcare risk holder. What happens in hurricane or blizzard scenarios? People don't seek the highest cost of care. So it's a horrible thing to happen that displaces families, that make hospices go on edge. But for the risk holder, which in this case CMS, it's a great thing because they often don't see the kinds of care that happen in those days where people are either undercover or covered by a blizzard. They don't see the kinds of care. So paying attention to those things aren't things you should do as an organization, but you need to understand those things are going to drive outputs. We know an ACO very well in the state of Florida that didn't make its shared savings check because an actual hurricane kept them from being able to manage costs during that window of time, and they missed it by that percentage, and it literally ties back to that. So you have to understand your patients, you have to understand the population, you need to understand risk adjustment factors. Today, as hospices, you typically aren't documenting and coding care for anything other than the terminal illness, but you're providing it. You're providing the therapies, you're providing the medications, you're providing all of the care needed. But in the future, to get higher reimbursements, you're probably going to be tied to those coding opportunities that you should be coding in the future to be able to get reimbursed at a higher amount. Just be mindful, we're going to help you through these processes. So I always like to think about, okay, expectations. You've talked about what CMS is doing. You've talked about the fact that there are these programs that roll out. You gave us a little bit of a highlight show on what Primary Care First and SIP is. Let's talk about what the expectation should be for an organization that's on this call with us, that's going through this program and thinking about how they move from maybe to a firm yes or a firm no. And the way that you need to think about this is that the current makeup of this program looks at what we would call primary care, which is that top bullet. That primary care component is the persons that show up in a practice for a specific need. It can be a sick visit for flu symptoms. It can be my annual wellness visit. It can be welcome to Medicare. It can be any of those things, but it is truly of the day. What palliative and hospice, by our definitions, are about much longer than that of the day. You're trying to manage goals of care. You're trying to manage symptoms. You're trying to manage behaviors and interventions. And so the federal government has always looked to parts of the ecosystem in healthcare to solve for the fact that most people go from that care of the day, primary care, into something that looks like a hospital stay. And what you have the opportunity to do in this primary care is to be a strategic win for you is to operate like you always have. So on the bottom right of this screen are the capabilities you've built at scale, your ability to manage the end of life, understanding what a patient's needs are as they get close to the last corridor of life, understanding how to manage symptoms, understanding an interdisciplinary approach, understanding how the process flows of that particular set of scenarios take shape. Those are your strengths and opportunities. Any primary care that's worked all its life on the of the day type of care, this is their weaknesses. These are their threats. They would see getting to be where you are as an operational gain. They've got to go hire staff. They've got to go build processes and programs. That's not what they're going to do. And in this first year, you are incredibly well positioned to take your strengths and apply them to this program. So remember, whether you have whether you have pre-hospice as palliative or advanced illness models, any of those things that you've been doing them knowing you've got to pay for the lion's share of that innovation. The federal government is going to pay for it in this particular program. And then I'd like to talk about implementation. So think about it, what it is to be successful in any future iteration, whether it's the carve-in, whether it's a CON adjustment in your state, whether it's any of those things. Think about how much you've built as capabilities that drive specifics that are related to how nimble you can be. No primary care that I've ever worked with, and we've worked with some significant primary cares taking on full risk for patients, want to be in the position of managing 24/7 care at home. That is not what they're built for. You're nimbler in that perspective. You should also be able to quickly repurpose your staff and them so that you can do more of the work that they need to do to be successful for them. You should look as much as you can to lock in partners with MA and large independent primary care practices, because you're going to refer to them. Guess what? You're a practice. You're going to refer to them for their specific primary specialty, and you're going to get referrals from them for your specific strengths and opportunities related to end-of-life care. And then I would always look for early and intermediate indicators of success. Develop champions in your earliest parts of this work and get a first day readout, a second day readout, a day 5 readout, a day 10 and day 20 readout, because you will find that you quickly see that there are things that bubble to the surface that you can address, and we should be able to address those on the fly as it relates to the needs for these kinds of programs. And the last thing that I'll say, when you take your first steps in this journey, applying your capabilities to what seems like a thoughtful or reckless, depending on your perspective, CMMI program, first things first, think about what you don't know today and how, if you knew it, you could be wildly more successful. Think about if you knew today what the next 12 months of your hospice pipeline was going to be by patient, by the number of needs they have, by their palliative score, by their frailty, by their family's availability and support. If you knew that today, you would be far stronger as an executive in your ability to sort of predict what tomorrow's census looks like, what your staffing model needs are, how you're going to fill gaps in either people, process, and technology. This is that program. This is going to give you population consistency. It's going to give you the ability to look out 13, 25, 36 months. When you look at this program, it's a 5-year program. You also need to look at things that you're going to be measured on in a program like this. They always care about acute utilization. The emergency room is the #1 way for that thing to occur. So let's understand quickly how we can manage and, where possible, divert an acute event from happening out of the emergency room triage that can be case managed well. Polypharmacy is another big item. The number 5 killer, don't tell anyone, in the United States is medicine itself. Adverse medical events, if you add them all up, is the number 5 killer in the United States for its patients. And the biggest cause of that, is polypharmacy needs. Patients who get so fragmented as they start to manage ESRD, congestive heart failure, oncology, and other journeys, they're on so many different medications that a patient journey into some new site of service adds a new medication to the mix, and now they have an adverse medical event. That's the number 1 cause. And then get really confident and close to the folks who should be your referral sources. Those are the community, I'll call them ologists, so pulmonologists, nephrologists, cardiologists. Get close to them, because parts of what your primary care referral back to can be back to one of these particular organizations. So be mindful of that. And then obviously with your social worker and chaplaincy components, the social determinants of a person and their needs are important in this particular day and in the future. So let's talk a little bit about primary care itself relative to primary care first. And I'm gonna make specific reference to primary care in 2 different ways. Option 1 in this particular model is what we would all understand as the classical definition of primary care. Sit down, because option 2 is the federal government's definition of a severe illness population, primary care. Because what they see in this particular fragmented population is the need for someone to coordinate, stabilize, and then manage a transition plan for these patients. So if you could start working on a population of 4 to 6% of Medicare, again, that's the decedent rate, so be mindful of that. If you could start working on them and have a 12-month period to use your infrastructure and your call center related to intake and access, to use the infrastructure you've built in the field related to pre-election services, to do the community outreach that you might do around advanced care planning, or any of the services for respite care that you might do in any number of shapes or sizes. All of those things you've been doing that you've written off as a cost to your business, but a value to your community, you're now going to get paid for. And you're going to get paid for it as a practice. You will not be a hospice agency in this world. You will bill Part B. So if you've built that palliative practice that we asked about in the beginning of this particular webinar, you're already billing Part B. So there's no stretch for you there. You're not going to have any stretch marks. The magic that you're going to get to play in this world is you're now going to get to be a referral source. And the federal government is removing 2 big obstacles for hospice in this new paradigm. They're removing the requirement for a referral, and they're removing the requirement for a 6-month prognosis. So let's talk about what this means to you financially. So for the folks that are on this call, I'm hoping that many of you recognize your state or the markets that you serve on this map. We've shown it a little bit before. This map showcases that, and these will adjust nationally based upon the actual cost of care, but a rough order of magnitude for the rest of this conversation is going to be about a $300 per patient per month payment in capitated payments paid to you, whether you see the patient or not, after that first month. So the federal government is going to what's called attribute, or create attribution for your practice. That word's important. And you will sign up for every practice that you have. Guess what counts as a practice in this particular program? Any address that you have for any brick and mortar that you have the ability to provide care from. It doesn't mean they come to you to see you there for care. It means that you might launch parts of your community-based team, and that might be a huddle location. It might be a clinic of some sort. It could be your PACE organization. It could be any of the things that you have that would literally qualify as a brick and mortar address. And you're going to field patients that get attributed to you in a pro rata fashion. So the federal government's going to look at applications. It's going to accept a number. We think that number is between 5,000 and 10,000 practices, again, by address, across these 22 states and 5 markets. So you get to see them that first month. You get to collect $325 that first month. You can keep them in the program for up to 12 months, and you get to collect monthly roughly $300 a month. So the magic of that number from a financial perspective means that we can start working together with what you already do and positioning your team's approach incrementally to be successful for the carve-in that's coming, to be successful for the next iteration on SIP, because it's coming, just like the ACOs have iterated 9 times. We should expect that over the next 9 years, just to use the same math, you're going to see the same kinds of iteration taking place. So how do I prove in this quick webinar that you guys are eligible? Here are the requirements to participate in that second model. You must have an interdisciplinary care team approach. So I'm assuming everyone on this call employs physicians, nurse practitioners, some form of care manager, RN, and social worker. If you also have behavioral health pharmacists, community service coordinator, or chaplains, great, those are additive. But to meet the requirements, you just need those first 4. You need to be able to deliver a comprehensive person-centered. Remember the vernacular around, you can't say I'm going to run on raising taxes, you got to run on quality. You got to run on voter-centered or patient-centered components. This is that language making its way into the eligibility. So be mindful, you have to be able to look at the person as an individual, and you need to address not only their clinical needs, like their symptoms, but also any social needs. So they have issues getting their medications, translation services, transportation services, food bank, et cetera. Those kinds of things you already do. So imagine being able to document in an application what you've done. You need to have relationships in the community with medical resources, not only the ones that you would support traditional clinical needs, but also social needs. And then obviously you guys do healthcare planning. Parts of what you're going to get measured on is, did you develop an vet's care plan and directive? Do you engage the family and caregiver? And then do you have 24/7 support? So my big box at the bottom is you guys are uniquely positioned. The other reason you're uniquely positioned is all of the next-gen ACOs are locked out this first year. All of the comprehensive primary care plus practices are locked out the first year. So of those 5,000 to 10,000 practices that are going to come in, you are in the catbird seat because they're locking out other innovative organizations who might jump in. So this has been a contentious point for all of us for a while, because I think we would all see this timeline looking like we're starting to miss even the latest adjustments that have been made. We've gotten some behind the scenes evidence that makes us believe that this model will actually open up its application process in the month of September, as had been previously discussed. We believe that they'll follow through and have a very short window to accept applications. We believe that the payers themselves will be solicited as they were for CPC Plus and before that CPC. There was an incredible bit of activity and success of getting those payers in. And then you'll start getting your election notice that you've been selected, and then you'll sign a participant agreement on or before January 1st. That is the first time you will actually be legally tied to these programs. You can do a non-binding application. You can look at the data they're going to give you. You can go through our assessment. You don't actually launch into this model until you sign a participant agreement. And oh, by the way, you can always meter how many patients they give you. If you start to have issues with staff or service line issues, that can be metered on this program at any time. So one of the things that we always think about with any agency or organization that's looking at what probably seems like a fairly daunting set of changes is you almost can't not participate. You have to think about jumping in. It's a bit of a prisoner's dilemma, if you're familiar with that. If you are in a state and you choose to sit on the sidelines, you're not only allowing the other agencies that might be hospices in your environment to get a leg up, you're also allowing primary care to figure out how it's going to support 24/7 access. It's going to create an interdisciplinary approach. I would suggest that you make quick use of this first year for another reason, which is that we've seen every new model, every new program only implement with carrots, meaning there are no penalties, there are no reasons that you are going to get, beat about the head or neck during this first year. You're going to make it through without a lot of pressure, but they're going to use incentives in the form of dollars to ensure they get the kind of pull through that they expect. We also think it would be incredibly advantageous for us to have a 12-month hospice pipeline just to be able to support how you have that visibility to drive staffing decisions, to drive program development, to drive what in the world are we going to do if the CARVIN changes in my state? I'm sorry, if the CON changes in my state, or the CARVIN continues to be a force and factor we have to reckon with. We know that these programs, while they might not seem like it's game changing because it's going to afford community primary palliative care at $850 a month or something like that, it is going to be able to afford becoming a suitable practice. And in this suitable practice where case management is the kind of paradigm, you get to case manage these patients and transition them directly to your agency, which I think is a huge benefit. So last couple of things. I think we always get fairly myopic when we see something new that we don't recognize. There's a process called the amygdala hijack, if you're familiar with any neurological studies, where when we see too many variables that we are confronted with, we often sort of fall into fight or flight. And I think part of what is typical in human nature is that that's going to be what some of our hospice agencies choose to do here. And I want us to get outside of our own comfort levels for a second. This is a map, and it's dated. You'll recognize the study. It was from 2002, but this is a map that looks at what was the total opportunity if the federal government's paying attention relative to states who are performing fairly well, and what is the total opportunity in the states that have been lacking in performing well against the hospice benefit. And I want you to recognize that they haven't picked these states willy-nilly in this program. Their expectation is to make use of some really great performing states, some with CON, some without CON. They're looking at the utilization not only in hospice, but the acutes. They're looking at where capitation in the primary care world has been rampant for 30 years. Look at California coming into this. So our expectation is not to have us think about what hospice does, and not to have us think about what hospice could do. So this slide is looking at the darker the blue, the shorter the length of stays are. So look again at these maps and think about what the federal government would be looking at us about, which is you have these opportunities where you get a ton of hospice utilization. I'm going to pick on my home state of Florida, but oh, wow, is that a really short length of stay that you guys are getting for a lot of those patients? And oh, by the way, you know, palliative is a great thing for all of us that understand what it is, but 70% of Americans don't. So they have to build new paradigms that allow us to fit into a world where they can create new vernacular, and CMS can do it, by the way. Do you know how many patients are in love with CMS or from their Medicare benefits? Most of them that elect the fee-for-service component, guess what? They can go see any doctor that they want. So this is a mechanism to ride the coattails of what a lot of folks see as an incredibly valuable component as they age in America. So think about that from, again, cognitive empathy. They're trying to figure out how to solve the problems of keeping Medicare solvent, and they're recognizing that if they put enough of these cohorts that are good in certain instances, potentially not great at getting referrals and long length of stays, let's see what happens when we give them their own opportunity to have their own hands on the reins. Here's the bet they're making. If there's a gotcha, aha, holy cow moment, this is it. So the blue bars on the screen represent the total number of Medicare deaths. 2018 data will be out in October, so we have to use what they used. The bars represent the total number of deaths across Medicare and Med Advantage. The lines above them showcase the low and high watermark that the federal government intends to promote into the seriously ill population program. If this doesn't create an incentive for hospice with the removal of a referral and the removal of the prognosis component to be able to have its reach completely exceed its current grasp and reach well beyond its current capabilities, because you're going to have the ability to drive what you've always been able to do when given the opportunity. You're about to be given the opportunities like you've never seen. This is a game changer. So I wanted to talk about one more thing. California is the largest population by total patients. I want to show the highlight here. Now we're not talking about the total number of deaths. We're talking about the total patients served by hospice. So that 142,768 patients were served by hospice in some form or fashion in California and in the 2017 service year. Remember, 2018 data is not out yet. So that number of patients look at the total eligible down in the bottom right. If we were to get the high end, that is 230% above what we served in the last service year that we can look at. So imagine now you're not having to build high cost community palliative. You should still do that. Nobody's saying that's not the right thing to do. What we're saying now is you have a funding mechanism to be able to have visibility to your hospice paradigm for as much as 12 months. And that pipeline can drive any innovations you want to deliver on the community palliative side or advanced illness model side or any other program paradigm you can stand up. So this is a single state's view of what is about to come down the pike statewide in January of 2020. So the call to action for this particular webinar is, we want to be a part, and NHPCO has tapped us to do, and we think we can get through the turnstile about 500 assessments between now and the end of the year. We want to be a part of your team. So we grew up, chasing the opportunity to thrive when these changes come down from CMMI and CMS. We think we are ideally positioned to be the perfect yin to your yang. We're not going to have all of what you know about how to deliver interdisciplinary care, but we're going to know exactly how to get through the application process. We're going to provide templated answers and responses to support that part of the engagement. We're going to analyze all the data that CMS gives us, not only pre-program, but every month when the patients themselves get attributed to this program. We're going to get up to 3 years worth of data in the initial rollout of the program, and then incrementally we'll get monthly data loads from the cloud from CMS. And in that data, we'll be able to report how sick are the patients, what their palliative performance scale is. You don't have to send a nurse or have an assessment done in person. We can do that from the data they give us. We're going to help you model what your staffing requirements would look like incrementally, because we know we can get 20 to 25% gross margins out of this type of program. We've done it in both complex care and chronic care, as well as bundles and ACOs. We'll do a full analysis of gaps that you may have from a people, process, and technology. I know there's going to be concerns about EHR certification. We'll answer to those things in our assessment as well. We know there's already one waiver. We believe that kind of concept will continue in either a time waiver or a modular-based waiver. We'll help you support filling any gaps that we identify in the community partners that you have opportunities to tap. And then, as important as Medicare is the non-Medicare MA plans that opt into this program. We saw big tranches of adoption in the previous versions of this program, and we believe that that same enthusiasm will align itself to this program. So we'll help you contract with the MA plans who are going to roll into this program on or about January 1st as well. And then lastly, this isn't just the Acclivity team. We've tapped industry leaders. So Dr. John Mulder is a part of this assessment team. Arif Kamal, Duke, gentleman who's physician and fellowed in palliative and oncology medicine, is a part of this team. He's also our chief medical officer. So we have strength to ensure that the opportunities for you to be successful aren't just myopic in our own lane, but also include what you guys believe are, as we do, luminaries in the market. So we're looking forward to aligning to you guys. I think there's a mechanism for us after this to be able to get your questions, but also allow you the opportunity to get us engaged through an engagement letter to do the assessment with you. And NHPCO and Acclivity have built a partnership that gives you guys nationally a 10% discount. So that's a huge benefit for the folks that adopt the assessment as well. And I think we have one more polling question left to do, and then we'll take questions and answers.
So we didn't really talk about direct contracting entities, but I think that we have talked about that in other webinars that we've done on these topics. And that's another way to engage, and those are more like the ACO types. We already know who's got letters of intent out there, right? So if you were a hospice, would you be checking, Jeremy, on who might have signed a letter of intent in your geography and reaching out to them?
Yeah, and they will have a need, yes, succinctly yes, and they will have a need to find partners that they narrow a network around. So be mindful that that is just the next iteration, and we almost jokingly call it next gen plus plus, right? It's the next iteration on that kind of concept. We certainly would love you guys to start making those introductions with us if you're so inclined, but certainly on your own with your business development staff and strategic initiatives you have in growing your hospice, because this is the precursor to the carve-in. So if you can build those relationships, it would be a heart and lung transplant for them to take you out later once you're already that much involved in those particular types of contracting entities. So it looks like we've got about half of the folks that vote. I know that's far more complex, so we'll end the polling and show you the results. This is very typical of sort of what we would expect to see. Much more complex. You have to manage many more moving parts. You need a large population, like the ACO. There's a minimum requirement of 5,000 lives being managed. So you'd need to partner to be able to get there. So maybe, unless you have already partnered, is a great answer, because you'd have to work through, who are the persons in your community that are geographically aligned, but also in appropriate kinds of positions to be a good partner in a narrow network. So I think we wanted to use the last minutes to chat about questions, and I think we're going to take the questions via chat.
Yeah, so we've had some throughout the course of the webinar so far. A handful of people have asked, what about the states that weren't chosen? Those who weren't in the blue states, what do you have to say to them?
So our early guidance would be start preparing yourself for this being 2021 for you. Our expectations are that the federal government has to use as many levers and oars in the water as possible to right the ship. And if this program shows what we believe it will, which is diminishing total cost of care and right-sizing patients getting care at home, then 2021 will be the start date for the rest of the states that weren't colored blue in this current program.
Okay, so I have a lot of questions from specific states. So as far as you know, there's no wave 2 for specific ones past this initial launch?
No, our current insider intel is that it'll be the rest of the states if we do what we're supposed to do. And again, this is why, if there is an opportunity for all hospices on this call and in future times when you're listening to the playback, this is the time for us to all be cooperative with one another, because doing what we should do in this particular iteration ensures all of the rest of the states come online next year. And sitting on the sidelines, while it might seem like it's a smart thing to do for your agency for any number of reasons I'm sure you can come up with, you actually lose the ability to be the lead dog on what the next iterations look like. And they're gonna get feedback. And if you're not involved, they're gonna get it from other entities.
Okay, thank you. So in the states that are in a corporate practice of medicine state, can a hospice itself apply, or do you need to be part of a medical group?
No, a hospice itself can apply as long as they have addresses and can meet the eligibility requirements. That's our current understanding. There are going to be probably between, CMS, so 100 pages of regulations that we'll have to sift through when they publish the application. But so far, they haven't limited by that particular factor yet in any of the things they published or talked about.
Thank you. So how are patients identified in the community and entered into this program?
So the federal government will use what it calls hierarchical condition codes to determine an HCC risk score. And that risk score will be the first factor. If a patient is 3 or more on the risk score, they will get automatically enrolled in this program. If they're a 2 and have 2 hospitalizations, so an emergency visit and an admission into the hospital, and that would also automatically enroll them. And then if by plurality of care, meaning that they are seeing a different number of primary type carers, where that total number of care isn't aligned to a single entity that is either an internal medicine, a family medicine, geriatrician, then they will also be enrolled. So those are the 3 ways that they're going to come in. And that, again, is why those numbers were so much bigger than the decedents. You're going to see a big influx based upon measures that don't have to do with prognosis or referrals. They have to do with a risk score and whether or not primary care is engaged to the level that CMS deems appropriate, which is 50% or more.
Okay, so to piggyback on that question, does enrollment of a patient from a PCP organization or ACO eliminate their ability to bill for CCM payments?
So no. So all of these programs will pay only once, though. So I'll make that clear. If I'm an ACO and my patient isn't being well managed and finds themselves at a risk level and a management level, so plurality of care level, where they get pushed into SIP, the federal government's only going to pay for the services of that patient once. So if the ACO is in a Medicare shared savings ACO where they aren't going to get their check until October of the following year, that check will be diminished by the SIP payments that went out to pay for the fact that you weren't managing these patients well in the first place. So the hospices, again, are in the catbird seat. They get to become, in essence, the primary carer, and they get to manage these patients when appropriate into their hospice services. And they are the affected positively. The only persons that can be affected negatively in this whole program are the hospitals, who the federal government is attempting to diminish utilization from, and ACOs who haven't managed their patients well. Guess who manages patients poorly in ACOs? Hospital-led ACOs, because they use the ACO to steer patients through the hospital, which is exactly not the intent of an ACO. So the federal government's wise to it, and they've created a program like this that allows an ACO to be created, but if you're not going to operate in the appropriate guideposts we've set for the program, we're going to get these patients to get into a different program, and you're not going to get as much of the savings you could have generated otherwise.
So we just have a couple minutes left.
Mm-hmm.
One more question was, can you expand on the no need for referral or 6-month diagnosis statement that you've referenced a few times?
So the federal government isn't going to use those attributes to make attribution. I should come up with another word. They're not going to use those particular components to attribute patients to SIP. That's a hospice set of paradigms, right? So when you get a SIP patient into this program, you're going to have the opportunity as a practice, which is how the federal government's now going to define you in this program. You're going to bill Part B. So think about what that means. You're not an institution. You're now billing Part B, and you're going to have the opportunity to refer to your Part A hospice. That's the referral requirement. That means you get them before that, and you have the opportunity using your social workers, your case managers, your nurses, your chaplains to align patients who have decided and defined their goals of care are comfort measures only and independent and at home as much as possible. And you're going to follow those guideposts to get them into the hospice by referring them from your Part B practice to your Part A hospice.
And what did you say was the number of hospices that will be accepted into the program?
So we don't know the number of hospices. They define everyone in this as a practice, and the practices are by a zip code and traditional brick and mortar address, so no PO boxes. But they are going to accept between 5,000 and 10,000 practices. So the good news, again, for hospice is primary care is locked out if they're part of a next-gen ACO, which are very innovative practices, and if they're part of CPC Plus, which are the other fairly innovative practices. So those two things mean that hospices should get, I mean, if we're just kind of guessing rough math back of the envelope, 80% of these slots. You should go get every one of them that you can.
Okay, so the last few questions were around the cost of services and what comes next. So I think we have one more slide with some contact information, but do you guys want to just close with the part 2 of this webinar where we'll get into some more information?
Yeah, we're going to have a part 2 in early October, so October 3rd. So watch for that and register for that. And Jeremy will be going into a deeper dive, right, on some of the ways that Acclivity can help the field with the application and the operation.
Yeah, and I think one of the things we can do in between now and the 3rd of October is we believe the federal government's going to open the application process. The sooner that you all get into our jet stream, if we're going to push 500 of these assessments through the turnstile, I would hope that you guys want to be in the front end of that. If you are, you get a little bit of a benefit. The more CMS delivers in this iterative approach, the more we're going to have to go back and retool what we've told you. So you're going to get more of our time. That's the compelling event from my chair as a CEO to some of the leaders out there is to do it sooner so that we can help you sooner. And then if this opens as we expect it will in September, we're going to be helping a lot of folks get through the application. I know it's going to be a snowball. It's going to build momentum. I would like for some of you guys that are yeses already to look us up. Send an email to info@acclivityhealth.com, and we will immediately be able to supply evidence. And you can also, as you see here, visit nhpco.org/edge and be able to complete an interest form. That comes to both NHPCO and it comes to Acclivity. So we'll be able to immediately respond back with prices, the scope, the outputs, and what readouts you get from us in this process.
And I think one thing you've told me a couple of times now, Jeremy, is size of the organization shouldn't preclude them from considering participating.
We have agencies that are under 100 average daily census, many of them way under 100 average daily census, all the way through folks that are above 2,000 in census that have been through this assessment with us. I will tell you, one is not better than the other than from the CMS perspective. If you can address the number of practices, you're going to get pro rata the number of patients in your community. So bigger may mean you have more addresses that you can put as an application. That would get you more of the opportunity. That's the only difference. There isn't a set of capabilities or a set of services that size somehow dictates you're more appropriate for. It really is just about a pro rata round robin that they're going to do when they start to deliver patients through attribution.
And they will, in a certain geography, they will kind of distribute equitably, or at least that's their intent.
It is, and it'll again be based upon what they figure out as factors that say you can get this much of market share versus that much. And we'll know some of that. We know it from historic experience, but we'll know some of that as soon as we see what they actually deliver as their questions. And we'd love, again, to help you guys position yourselves in your communities to look the right size, scope, and capacity to support as much as possible that's going to come through. Because this is again, it's a game changer with the size that they're pushing out.
Well, thank you so much, Jeremy, for your time, and thank you for being an NHPCO Edge partner.
Sure.
We are thrilled to have your services available to our members, and I hope that everyone heard they should be jumping on this opportunity.
Yeah, we're excited, and thank you for the opportunity to be an Edge partner. It's going to be, I think, a great partnership, and we hope we deliver a lot of value to not only NHPCO, but all of its members.
Yeah.
All right, thank you.